talk about hip replacement and exercises that usually we do after hip replacement. We also talk a little bit about how we get the candidate to have a hip replacement and what's the hip arthritis. Also, we want to recognize why we're getting hip arthritis and what's the causes usually, and what's the prevention basically, some preventive exercises. So first of all, we're going to start from what the hip arthritis is. First of all, I want to know that, want you guys to know that hip arthritis can have stages. In early stages, we can really be helpful in physical therapy for the patients, but in later stages, unfortunately, because it's the joint that the ball is located very deeply in the socket and is not that much dependent to the muscular strength around it, and the stability of the joint is not happening by the muscles, mostly happening by the form of the joint. If this joint is not healthy inside in the cartilages of the joint and joint surfaces, the muscle strengthening only can do so much, cannot perfectly control the symptoms and help with the hip arthritis in the later stages. Especially in the later stage, they lose the range of motion and the hip becomes really stiff, and that's going to be a big problem. So first thing we want to know, what's the stage of it. So best thing to do is the hip x-ray, very simple x-ray. If the hip x-ray shows that we are in the stages that, if you can see, I'm not sure if you can see that or not, what stage you are. As you can see, this side of the hip, this side is not as bad, but the other side is very severe. You cannot even see the joint line. The joint line is kind of shadowy, and you cannot see any space between the ball and socket, and you can't even see a couple of erosions and bone spurs inside the joint. That's showing that, okay, we are done with probably with physical therapy, and we have to think about the hip replacement. But if we are in the early stages, we can do some stuff still. Usually in the late stage, unfortunately, people get dependent to the walker or cane, and the reason is because the hip joint is supposed to take all the pressure of the upper body. For people that are especially heavier, more overweight and less active, when they get the hip arthritis, it's gonna be a very, very hard situation for them to put the weight bearing, put the body weight on the joint and walk and balance themselves. We get prone to fall. We get very, very bad range of motion. We can even take the steps. They cannot take the steps because the steps gonna get short. They can walk like we call it waddling gait or Tellenberg gait, because the muscles around it get so weak because the hip's not really functioning good, and they really cannot open and close or do any rotation on the hip. So there's a lot of problems in the range of motion, a lot of problems in terms of pain, very severe pain, especially with weight bearing. They get dependent to assistive device, fall issues, balance issue, because the hip muscles are controlling our balance, definitely, especially glute medius and glute maximus, especially medius here. They can help the pelvis to get stable, and the single leg stance, when we stand on one leg, we really need the hip muscles to help us with the balance. A lot of issues happening, so that's why the hip arthritis is a very severe problem, and hip replacement is very life-saving surgery. So before the hip replacement, if we have some issues, it can make us more prone to the severe arthritis later in life. First thing we talked about in the last video was hip malalignments. Some anteversion, retroversion. We talked about people that walk in toe. They have problems with the internal or external rotation. Usually they have excessive turning in the hip, and sometimes they walk with the in toes. Sometimes they don't walk with the in toes, but they have enough internal rotation of the femur to have an impingement in the inside of the joint line, or in the front of the joint line. Usually sometimes they have a lot of tightness in the hip flexors, so the femur bone goes forward and impinge it anteriorly, and when they anteriorly impinge, they have to really stretch the hip flexor, as we already talked about. That was the hip flexor stretch that we already talked, right? And I can show you in this side. So that was the hip flexor we already talked about, hip flexor stretch, and we talked about lunges and stuff like that. So today I want to know why we can get arthritis other than this problem. The labrum tear is another issue. Labrum is the cartilage that kind of carpets inside of the acetabulum very nicely. As you can see, that cartilage that is like a real carpet for the inside of the acetabulum fossa. So it's a real cushion for us. If that cushion tears, you see how it tears in the red? That's tearing there. And then if tears, then we have to repair it. Sometimes the repair surgeries are not as successful because, as I told you already, this is showing you how they repair the torn labrum. Sometimes it's not good because it doesn't have enough blood flow to get together finally, like a bone or muscle that they really heal completely and fully. The cartilage usually doesn't heal completely. Other than that, if we try to push it with some kind of PRP or some new techniques to injecting platelet and blood cells to it to get more blood circulation and try to force it to heal. But it might not heal fully depending on age or other problems or some deformities or being overweight and other stuff. Being active especially or not. So basically the thing that we want to offer when they have a labrum problem is mostly a strengthen a structure around it and stretch and distraction. As we talked about, we distracted the joint using this band. In this last video we can talk about it again. But I want to talk about one test that we can run to make sure that if we have a labrum tear, or we probably have a labrum tear. So usually in the weight bearing, we have a lot of pain in the groin area, inside deep pain of the groin or anterior deep pain of the groin is usually because of the labrum tear. But if it's a superficial pain here, it might be mostly the hip muscular tightness that we have. We usually have a lot of muscular tightness or ligament issues in the anterior part of the hip and inside of the hip. So, but another the test that we can run for ourselves, we can put our knee like here and then try to do a little bit internal rotation and then we go like this and that. If we get pain with pinching feeling, then or a lot of cracking and pain when we try to push and go in and out, then we might have a labrum tear. Depending on how severe the labrum tear is, we can really treat that. So the first thing that can help us for the labrum tear is, again, the distraction. Just gonna over that real quick for you guys, for whoever that didn't see the previous video. This is going to be the distraction. So we're trying to distract that using the elastic band, okay? So let that hip relax and try to distract the hip joint. Pull it and let the pull stay and come back. Okay, and if the impingement of the labrum is mostly internally, so we want to try to bring the hip against, with the help of the band, we're trying to bring it like outwards a little bit. So we're gonna put this here. I'm gonna put this in my groin. It's better to be in the groin area. You can go down there too, but it's better to be in the groin area. So we can let that band to pull our hip a little bit, our femur bone, pull it outwards, take the pressure off of the inside of the joint, or you can be in that position, having the same, trying to get rid of the extra tension. Make sure it's on the joint line. And if the tension is mostly in the front, so you're gonna do this way probably. Try to have the band help you to pull this femur bone back. So these are self-mobilization. They are very nice thing to do for people with a lot of impingement or problems in the labrum. So they can get rid of the extra pressure basically. Another thing is gonna be definitely losing weight. That would help a lot. And then we test to see what muscles are tight. So how to test for the tight muscles? This is the best test for you to use if your hip flexor is tight. So you're gonna bring this up on your chest, and if this side comes off the floor, it means that the left hip flexor is tight. Okay, if it stays nicely and you're to the knee to chest and the other side, then probably you don't have issue with it. Other side as well. So you're gonna go knee to chest. If the other side comes off the floor, then you have tight hip flexors on the right side. So that's how you test that. If you found out that you have hip flexor, there's a lot of things you can do. First thing, which is easier, you're gonna do this way. You can put a pillow or something underneath your knee, and then you can pull your leg. That way we're stretching the rectus femoris muscle, which is the part of the hip flexor, nicely. I can show you on the other side too. Okay, hold it for 30 seconds. And of course the other two that I already talked about. This is going to be this one. Let me show you this side so you can see better with the pelvic tail. Hold it. And then definitely the lunges. Hold it 30 seconds, release, right? They are decreasing the tension for that area. Some other thing that can make you prone more to the hip labrum tear and other hip arthritis later is going to be the having the trochanteric bursitis. Some people have a lot of pain in that area. That's the trochanteric part of the like a prominent part of the bone. Some people that lay down a lot in one side, in the hard surfaces especially, or some people that have a wider hip, while they lay down on the side, they get a lot of pain in here, in the side of this bone, and we have a bursa underneath that, between the bone and the other tissues, and this bursa is filled out of liquid, and that can burst even or get inflamed. And if it bursts or get inflamed, so the tendons of the muscle in here gets a lot of inflammation and problems, and basically your glute medius muscle, which is the most important muscle of our body for balance and walking, that can get weak because of so much inflammation. And these people, they walk really with a lot of Trendelenburg gait, so they really cannot walk because this muscle is not holding them. They cannot put one foot on the floor, they cannot balance themselves. So that trochanteric bursitis is usually acute, and with the injection or some physical therapy like ultrasound laser or cortisone injection and stuff, it can go away. But if it gets chronic, then it's going to cause weakness, chronic weakness in the gluteus medius, and they have to compensate with IT band, which is going to be an issue again. And it's going to cause more problems because when the muscle doesn't work here, then it's going to be more pressure on the labrum and more possibility for future arthritis earlier. So we have to be all careful about everything, like bursitis, alignment, as we talked about as a kid, as an adult, all kind of injuries. Think about labrum tear if you have it, cracking, if you have a cracking or snapping of the hip for a long time, or if you have a rotational issue. And then if all of this can be caused to the arthritis, okay, and then the next level is going to be they losing the range of motion. They cannot really move it outside, inside, going up anymore. All of these motions can get really, really limited, stiff, and very problems in the walking. So then it's going to be hip replacement, and I'm going to show you the picture of the hip replacement, which is a very, very successful surgery. It's been there for a long time. You see, instead of bone on bone, we're going to be metal on metal, not iron, like an Iron Man, and we're not going to feel anything, any pain anymore. Okay, but it's going to be a little bit hard. If people have osteoporosis or thinning of a bone, lack of vitamin D chronically, then they're going to have problem doing that surgery. So because they have to really dig into the bone and put the prosthesis inside the bone. If the bone is weak, it's going to crack if we try to drill it and then put the prosthesis in. So we have to really be careful. So another thing about after hip replacement surgery, very, very important to do the precautions, because as we talked about before, and I'm going to go more in detail today, we can have, they can go in from the back, which is a posterior approach. It's very old-fashioned, but it was very common until a couple of years ago. And they would go back here, and they would cut some tissues or some muscle in here, especially the glute muscles they had to cut, and then some capsule, the posterior capsule of the joint, to be able to dislocate the joint and then put the prosthetic and put the joint back. And then they had to sew the muscles and sew all the how do you call it, all the structures like the capsule, joint capsule and everything, sew them back. And imagine if we sew them, we have to give them a lot of time to heal. And if we do something wrong before that, the area that we sewed and is not healed, it can open up. So what happens is they should not go more than 90, because as you can see, when we go more than 90 in the posterior approach, we have a good possibility to have the head of the femur back, and it can open up the weak capsule that is already torn because of the surgery and is healing. So we have to be very careful about more than 90 degrees. We can dislocate the bone easily, and we can end up to the surgery room again. So this one is going to be really bad, because again, for posterior approach, it's going to bring the head of the femur to the side of the stitches, and it can make it open again, and we can dislocate the hip. So it's very important. Abductions usually okay, opening the hips okay, rotations are okay, especially external rotation. If we can do it, is okay. Internal, as we said, we have to be more careful for internal abduction, especially for this is a no-no. Laying on the side, they have to use a pillow between the legs when they lay on the side. So using the pillow, sometimes we call it abduction pillow, keep it in abduction. Don't let this go in here. That's the wrong. We shouldn't do this. So these are a lot of precautions that for a couple of months based on your doctor recommendation we have to obey. For people that they have a lateral or anterior approach, which is a newer technique, is a little bit less problems. So they can, for the posterior approach, they cannot even bend forward more than 90, because imagine even if we do this is bad, and if we bend more than 90 is same thing. Anything more than 90 degrees can dislocate the joint in the posterior approach. But if we have anterior stitches, we're going to make sure we don't go too far back, because we're going to pop it anteriorly, pop the hip forward. So that's going to be a problem. So we just have a lot of precautions for anterior and posterior. For lateral also, for lateral is most likely we shouldn't do that. We shouldn't do this in any kind of, after any kind of replacement. We shouldn't do abduction, we shouldn't cross the legs. That would be a no-no for most of them. But the things that we can do the bicycle. If you have some kind of stationary bike at home, definitely use it. Make sure keep the space between the seat and the pedals to have not to make that knee to chest, because if that knee to chest motion happens, especially in the first weeks, it's going to be a problem for people that have posterior approach. They can do a lot of isometric abduction, which that's my favorite actually. Let me show you that. It's going to be, I can show you with that big ball that I have here. You can use a pillow or something. Just put it against the wall or something. I'm putting it against the table, right? I'm pressing here isometrically, 1, 2, 3, 4, 5, release. 4, 5, release. This is gonna be safe for after labrum surgery, after replacement surgery, any kind of approaches. It's gonna strengthen the glute medius, which is most important muscle for walking and balance. It's gonna be a good investment for later on. Another one, we're gonna put this foot against the other one, and then we do external rotation. Looks the same, but it's different. This is external rotation versus the first one was abduction. So this is the first one, okay? Second one's gonna be this. Isometric, so we're not gonna have to do too much. We're just trying to strengthen and then build that glute muscles back again, okay? Medius and maximus. Another thing we can do is gonna be the extension. For the extension, we can do couple more things for having it isometrically. The first thing would be, this is gonna be a good approach, not 90 degrees, right? Not more than 90. This is a no-no for after hip replacement, so we can do this and press to the, with your foot, press to the floor. Isometrically contract the glutes. This one also. Isometrically contract the glutes, press, hold, release, right? Also this one, if it's not 90 degrees, we can do that. Press to the ball. That can give you a little bit more feedback because ball is bouncy. This is not still more than 90 degrees on the hip, so we are still okay. It's a good one for after replacement also in terms of isometric stuff. Hamstring stretch, you gotta be very careful. You have to do it just until here, not more than 90. And stretch your hamstring. If you're gonna stretch your glutes, definitely just up to here, which is probably not gonna stretch the glutes anyways, because stretching the glutes would be usually after 90, which is a no-no after the replacement. So, especially after posterior approach, I mean. If you have anterior approach, don't do this. But if it's posterior approach, you can do extension. You can do hip extension to strengthen the glutes. And it's non-weight bearing, is very easy. If it's after replacement, it's a common sense, but you probably wanna you probably not wanna do this position, right? Because this position can put a lot of pressure, especially when you have the other leg on the floor, but this one's not even that good of a position because you have to still put some weight on it in a weird angle, which can be more than 90 sometimes and can be dislocating the hip. So I would say laying on the stomach and then bringing the leg up and down would be a better option. And for another one, for the glutes, if you're in a better situation after the isometric, you can start doing this, but you're gonna have pillow in between. Make sure you don't go to adduction, right? Okay. You don't really want to squeeze the pillow. This is not a good thing for right now after surgery. You gotta save that for later because that can cause a little bit of adduction, which is not good for the after replacement. So if you're clear for weight bearing, which usually you're clear at the first days in the hospitals, you can do the walking. Walking is gonna be your best exercise to do. Try to walk and try to contract your buttocks when you walk to have an as normal as possible walk. You may not have enough strong glutes and you may limp at the first days, that's okay, but try to contract the glutes and walk as much as you can, as normal as possible. You want to practice walking on the heel first and then toe and keep that hip tight and try to normalize your walking pattern as much as you can, possibly. If you have a posterior approach, you're free to do this, staying on the under leg and do a little bit of a hip flexor stretch like this. But if you are having the anterior approach with your incisions in the front, don't do this. This is going to be a wrong one because it's going to dislocate your hip. But later on, you definitely have to do a lot of hip flexor stretch because hip flexor stretch is always necessary, especially post-surgical. It's part of a big family of hip exercises, the best hip exercises basically. And then after you start walking, you have to, and when you start having the normalized walking pattern, you gotta really focus on a balance. So this is a good thing I have here, is a little bit wobbly, so I can try to play with this and then stand on one leg. That's going to be an advance after weeks of the replacement, that you're really comfortable putting weight on one leg. You can start standing in one leg. It's going to be really hard because your glute medius is responsible to stand on one leg, and it's very weak after surgery. And this is wobbly, right? So you can do this, you can do this and that. This is going to be helping with your balance. You can start walking like this for better balance. These are a lot of balance exercises you can do, very simple. And then you can start doing the squat a little bit. The squat's going to be good for you. That's going to be a later stage, right? You're clear, you can even go more. It's going to be still not going to be 90 degrees anyways, but and make sure you open up your legs when you squat, your buttocks back, good form, right? And do a little bit of squat. You can even try single leg squat later on. In that stage, you're probably already clear for walking, even a little bit of jogging. Hopefully after 8-9 weeks or more, you're going to be able to really be good. And this is going to be the end of the story for the hip disaster. Hopefully you're going to have a new hip, new metal hip, and as an Iron Man or Iron Woman, you can have a better experience of walking and jogging. Even people can do biking and hiking and all kind of stuff if you have you don't have other issues going on. So if you later on feel some leg discrepancy, you really have to talk to your doctor. Make sure you sometimes check your legs. Make sure you're looking at your both heels. If one of the heels really more down comparing to that, which I'm just pretending, if that's the case, then you have to really talk to your doctor before it gets late. But usually it doesn't cause any leg discrepancy if you don't dislocate your hip during the timing of the healing. It must be pretty good experience. So hopefully with a lot of physical therapy after that, you can help your body to heal fast. But make sure, again, I recommend you guys watch these exercises, but always talk to your physical therapist and doctor and make sure when is the certain time that the doctor and the physical therapist wants you to start them, and if all of them are appropriate for you or not. Just always get a second opinion. And after that, you can really hopefully use these exercises as the help. Have a great day. Thank you for watching. Bye-bye.